Hi, this is Dr. Bob Dannenhoffer, Public Health Officer of Douglas County. This is going to be shown on the 26th, although we're taping it on the 25th, so our great staff can have at least one Friday afternoon off in this last year. We're doing all the questions by Facebook Live, so you cannot put questions in the chat section and get them answered today. Although if you do put questions in the chat section, we'll get to them on Tuesday next. So as always, we start at the world level and then move down to the local level to show you what's going on. So in the world, very concerning because clearly we're in a third wave. There's no doubt, but that if you look at the number of cases in the world over the last week, there is clearly a third wave. And the third wave is concerning because the third wave is happening in Europe, where the waves almost always spread back to the US, so that's a worry, and we're worried because there's very high levels of disease. So we're talking about number of cases per thousand per day. You know, we're at 9 or 10 now. These places having 70 or 80, so far more disease than we had at any time during this. So I can remember how bad it felt back at a time when we had it, so I can imagine at 60 or 70 it's really a problem. Apparently in Brazil and in places in Europe, they're running out of medical supplies, running out of beds, running out of ventilators, and that is really worrisome now, a year into this pandemic. So that's a big worry, and most of those are worrisome because variants, which are more contagious, are spreading in those areas. And the concern is that as they have a lot of cases in those areas, people will inevitably travel to the US, or people from the US will travel there and then go back and bring this disease around. So the increase in the world cases is really a worry. And it's also a worry because it's not just Brazil, but it's Brazil, it's Europe, it's Uruguay, it's the Middle East, and then these little places in Africa that are starting to heat up. And remember, Africa is one of my big concerns because Africa's had very little disease, very little vaccine, and they've not had it. And then, well, there's much of Africa which is quite rural. There's parts of Africa which are far more urban than any place I've ever lived, and this disease could really spread in places like Lagos or Kinshasa or Nairobi, so we do worry a lot about that. In the US, cases are clearly up. So they were coming down about a week or 10 days ago. You may have heard me say I'm worried that they've kind of flattened and they may go up. We had over 70,000 cases yesterday. So our rate is clearly going up. 70,000 cases a day is such a worry because we're starting to see lots of cases in Michigan and Texas, in the New York, New Jersey area, and again, the New York, New Jersey area, because that's where travel from Europe mostly goes. So if you fly to Europe, you can fly from lots of different cities, but overwhelmingly, people are flying from New York. So when I see a big uptick in Europe, then you can expect a big uptick in New York. And we're seeing a lot of cases in New York. And then we're also seeing little scattered places, a place in Wyoming, eastern Idaho, that are really worried. And Miami is also a big worry. The case count in Miami is high, and there's all of these young spring breakers going there. And my concern is they get the disease and then they'll spread it back to the areas there are. It'll take 3 or 4 weeks for that to kind of show up in the numbers. But my concern is that by mid-April, we're going to start to see an explosion of cases in little places around the country where someone who was well went down to South Florida. They went to a bar, went to a party, did something with them, bring the case back. The young person gets sick in Ohio, that they then spread it to a bunch of others, and then the next round are going to be the people who work in nursing homes or whatever that spread it. So what I'm worried about is that come mid-April, we may see an explosion of cases in the US. I guess Miami was bad enough that they actually had to do a curfew in Miami. In Oregon, we've been quiet except for southern Oregon. So Josephine, Coos, and Curry counties have had more disease than they've ever had at this time, and they're having these funny outbreaks, so we're not exactly sure what's happening there. In Douglas County, we're down. So we've been less than 10 cases a day or so for the last week, which is great. We're in the high range, and on the day this airs, which is Friday, things will be open to at least 25% of capacity, and that is really, really, really a good sign. In terms of vaccine, we were supposed to get a big bolus of vaccine this coming week. It didn't arrive. And so the concern is that we're hoping is coming soon. But this week we got a little bit increased amount of Moderna, a little bit increased amount of Pfizer, but no increase in J&J. And so J&J vaccine is hard to get, although there are probably adequate supplies of the others. Also this week, early this week, we opened up to Group 6. That includes people 45 to 64 with underlying conditions, people who live in congregate care, pregnant women, and people who work in the farming industry. So that is that's a good thing. And so again, we have many places to get vaccine. We think we're working with pretty much every pharmacy in Douglas County, almost all of the clinics in Douglas County, 3 MS agencies, both hospitals, so there's lots of different places to get vaccine. Okay, let me go through the questions and then we'll go. So Donna says, I need to know how to sign up for the next drive-through immunization COVID clinic. I understand that it's coming soon, and indeed it is coming soon. It's coming on April the 3rd. On Tuesday, we are going to open it up, and the link is going to be open. Again, about 80% of the people sign up online. We think 10 to 20% of the people need help, and we'll have phone helpers help us with those. And so again, it's going to open up on Tuesday, and then it's going to be on Saturday. Some of the people we're going to see on Saturday are people who had their first dose back on March 13th. They have an appointment exactly the same time they had an appointment back on the 13th. For those who were at the end, they have an appointment at 2 o'clock on April the 3rd, but we'll between 7 and 10, and then after 3, we're going to do new people. We still don't know which vaccine we're going to have. Crazy that a week before, we don't know what vaccine we're going to have. We will have one of the vaccines. Certainly we'll have Pfizer. Whether or not we have any J&J is still up in the air. So Amy says, could this... So what is the reason that the drug that was used for schizophrenia showed promise in helping with COVID patients? So the drug is called fluvoxamine. So fluvoxamine is actually mostly used for treating people with obsessive compulsive disorder, sometimes with schizophrenia, but usually for people with obsessive compulsive disorder. If I say that a few more times, you'll think I have obsessive compulsive disorder. And it's because there's a thing called the sigma-1 receptor, which is one of the receptors that this drug works on that also seem to have a good effect on COVID. Again, we still don't have any further studies on that, but at least the preliminary studies on that drug, fluvoxamine, brand name Luvox, looks pretty good. So Chad says, if the P1 is more contagious and already here, it seems to me like we're starting this all over again. And it's just like a year ago, but we have lots of toilet paper stored up, so it's good. Yes, what we did see is that toilet paper sales spiked in the beginning, and now they're below pre-pandemic levels, presumably as people use up the cartons and cartons of toilet paper that they stored. Yeah, the variants are a big, big, big concern because they are much more contagious, and if they are much more contagious, they're going to be really that much harder to get rid of. So let me go through. I spent a couple of hours today working on the variants. And so the variants have very complicated naming and nomenclature, so they're hard to know. But I looked at the most recent data from the CDC. Half of their testing, and their testing isn't exactly a fair testing because people are more likely to send suspicious specimens than not, but of them, half were the variants, the B1, the B1.222, the B1.2. These are all considered to be fairly normal variants with the typical amount of contagiousness, and they're very responsive to the vaccine. So that's the good news. So half are the typical that. The bad news is the other half are the worrisome guys, including the B117, which is the UK variant that has the N501Y mutation that makes this much more contagious and perhaps more lethal. There's then the South Africa variant that has, which is the B1351, that has both the 501 and the E484K. So E484K we call EEK, and that's the one that makes the vaccine and the drugs work less well. So that's one we really worry about. Then there's the B.1.429, which is a Southern California variant, which seems to be more contagious. Then there's the B.1.526, which is the New York variant, which also seems to be more contagious and is thought to be behind the increase in cases in the New York, New Jersey area. And then the P1 variant that has lots of things, including the 501 and the 484, plus others, that makes it more contagious, likely more deadly, less responsive to antibodies, and the vaccine works less well. So these are the variants. And while we say, well, variants are rare, it was 50% of the most recent cases. And when you look at the graph that shows what's happening to the older forms, the B1, the B1.2, and then what happens to the newer forms is that the older forms are going away and the newer forms are really rapidly increasing. In fact, some of these are doubling every 2 weeks. Well, as you know, with a doubling percentage, it only takes 3 weeks to it only gets 3 cycles to get to 100%. And so, for example, some of these really are spreading, and that's the worry on the variants. So should we give up hope? No, because some of the places that have had variants, like South Africa, really with a lot of work and a lot of public health work, we're still able to keep these down. The point is, if there's a lot of disease going on, so if in Douglas County we're having 30 cases a day, there's no way to put enough work into keeping it down. But if we had 1 case a day, even if that case was a variant, we could probably still keep it under control. And that's why my plea is that we work really, 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 really hard over the next few weeks and months to get a lot of people vaccinated and get the disease down to where we're at 1 case a day, 1 case every other day, in which case we then have enough public health and other stuff to really get this under control. I mean, to get it under control with an outbreak, to really get it under control, what you'd want to get is the person, really get all their contacts, and then some of their contacts all isolated and quarantined. Well, if you're having 20 cases a day, that would be 4,000 people at a time that was isolated. You just couldn't do that. But if we had just a single case, it might be 100 people or so. You could do that. And so that's why we have to bring the disease down before the variant spread. And I'm very worried about Florida, because Florida has one of the highest rates of variants. And if these young people go to Florida and have parties and catch this from the bartender down there, and then they bring it back, it could really spread. So that's why I think we have to really do that. So Clover said, if someone has had just 1 dose of the vaccine and has a 24 to 36 hour with fever, minor nausea, and fatigue, should they get tested? No. So if it's over in 24 to 36 hours and you got tested, no. I think that's probably a vaccine reaction, and you should consider yourself good. Another person wrote in and they said, I received a reactive note after my blood donation. So when you give blood, they do a COVID antibody test, and it's either going to be non-reactive, or if you either had the disease or had the vaccine, it's going to be reactive. So if you gave blood a month ago and it was negative, or 8 weeks ago and it was negative, got the vaccine, and now you're reactive, it means that you didn't have the disease before and that something happened in that 8-week time to make you have antibodies to it, which in this case is almost certainly the vaccine. So it means that the vaccine worked. So that's a good thing. One of the other questions is, are you seeing a lot of cases being transmitted at schools? And the answer is not a lot of cases, but we did see some. So we've seen a few outbreaks where staff who've been positive have given it to kids in the class. And I think that is consistent with the data that we got from the Marietta study in Georgia. And I think it's consistent with the CDC guidelines that say that kids can be 3 feet apart, but teachers need to remain 6 feet away from their students and 6 feet away from each other, because there actually does seem to be a good amount of spread among teachers. The other thing that the CDC noticed in that Marietta study was that most of the cases, or many of the cases, came from sports, and indeed a lot of the cases we see are related to sports activities. And again, we don't think it's necessarily happening on the playing field, but team members tend to hang out before and after practice. They travel together in buses, and that's how we think it spreads. Now, also with school, we did a little study, and so as you know, starting in January, first responders and teachers were eligible for the vaccine, which is a great thing. And so that's been a great thing that they were eligible for vaccine. And so we've now looked for people who've gotten sick, who have tested positive since February, and looked to see how many of those were vaccinated and how many weren't. So if 50% of the teachers and 50% of the first responders were vaccinated, and that's about what we think the numbers are, and the vaccine didn't work at all, you'd expect that if we saw 30 cases, half would be in the vaccinated group and half would be in the unvaccinated group. If the vaccine was 100% effective, you'd expect no cases in the vaccinated group and all of the cases to be in the unvaccinated group. The answer is that 28 of 29 were in the unvaccinated group. So 28 of 29, which would suggest the efficacy of this vaccine is well over 90%, which was what we were told. And again, 29 cases, 28 in the unvaccinated group, only 1 in the vaccinated group. It also tells you the vaccine's not perfect, right? Because the vaccine was perfect, you'd have no disease in the vaccinated group. We had 1 case in the vaccinated group. So still, if you're vaccinated, your risk of getting disease is low, but not 0. So you still want to be careful about wearing masks, travel, and all those kind of other things, as well as you don't want to give this to somebody else. So that 1 in 29 who got this disease could have given it to others if they weren't wearing a mask. So the recommendation is still to be wearing masks, but that the vaccine is really seems to be really effective. One of the other questions is about long COVID and improvement after vaccine. So long COVID is the symptoms that people get after they've had COVID for a while later, and they wind up with these long symptoms. Some are pretty vague, like fatigue, although the levels of fatigue that people are talking about are really extraordinary. So these are people who say, I used to be a marathon runner, and now I can out of breath and just basically have to sit down after going outside to pick up the newspaper. That's a degree of fatigue which is really uncommon. And the second is brain fog. So brain fog is the sense that I can't quite think clearly. Brain fog is seen with other things. After concussion, chemotherapy can do it. People who've been in the ICU will have it. But even people who had relatively mild cases of COVID are reporting brain fog. The other one is vague pains, especially chest pain and back pain. And the other one is shortness of breath with even the slightest bit of activity. So again, the person walking outside to get the newspaper, then having this shortness of breath. Now, one of the interesting things is what would happen to these people with the vaccine. So you gave them a dose of the vaccine and their body-mounted immune response. Would they get worse because their immune system was revved up, or would they get better because now they had more efficient antibodies at treating it? Turns out that we're not seeing anybody get worse, but maybe a third of the people who've gotten the vaccine feel better, considerably better, after getting the vaccine. So again, we don't understand what long haul syndrome is about. We don't understand why that's there, but it is good to know that maybe a third of the people who have those long symptoms really seen an increase in their levels of activity, a lessening of the brain fog after they've gotten the vaccine. So if you are one of those people that's had this, there should be no reason not to get the vaccine, and it sounds like a pretty good reason to get the vaccine. So next question is, if you were put in charge today, what are the 5 things I would do? So it's pretty unlikely that they would choose me to be in charge because I can be irascible sometimes. But if they were to put me in charge of the effort, get Dr. Fauci out of there and say, Bob, you're in charge and you tell me what to do, what would I do? So I think there are 5 things, and these are opportunities that we missed in the past that I think we really should do. I think the first one I have is we really need to have better research on promising hunches. So along the way, people had all kinds of hunches about what might work for COVID. Everywhere from nicotine, give people vitamin D, give people hydroxychloroquine, give people zinc, give people azithromycin, give people ivermectin. And the problem is that we have not done good research on these hunches. And so we'll get a little to this later. We don't really know what works. The only research that was done that looks reasonably well done is the Luvox stuff. But It is just shameful that we're a year into this and don't have a better study as to whether ivermectin works, whether hydroxychloroquine may work in some small group, whether other kinds of things would work or not. We'll get later to what we think works and doesn't work. But if I was put in charge, I'd say, look, we need to figure out how to do this better research on hunches. And the problem is to do a research study. Typically, if you're doing a research study in normal times, you'll set it up. It'll take a year or two to set it up, and then you slowly recruit patients, and then 3 or 5 years later, you know whether something works. And for typical times, who cares if it takes a year or 2 or 3 to know if a certain medicine works for that? It's certainly good to know, but there's not like this rush to do it. However, now there is a rush to do it, and so we need a better way to be into this. So could we really be a year into this and not know better about fluvoxamine or hydroxychloroquine, about ivermectin? I think hydroxychloroquine has probably been the best studied. It really doesn't show it works very well, but I think there's not been a good long-term study on ivermectin. The studies that are out there are all terrible. And there's a few studies on Luvox that show it works. But again, it's just one small study. We need more than that. So they put me in charge. First thing we do is we get better research on promising hunches. Still want to protect people's safety, but with 50,000 cases a day, it would only take 1,000 people in a study, which is like 30 minutes of people who are infected to know whether something works or not. And I will tell you, in other parts of medicine, we've had all kinds of stuff that is sort of like, oh, we should do this or we should do that, because we've not done the adequate studies to show whether something works or not. And so if I was put in charge, that would be the first thing. The second thing I would do is I would say we really need to work on antiviral treatments. So for many of the other viruses we have out there, there are drugs that are called antiviral drugs, which are sort of like antibiotics for viruses that work very, very, very well. So the way we got HIV under control was not with a vaccine. We still don't have one. Public health measures help, but that didn't get it under control. It is with extremely effective antiviral drugs. So these are drugs which now you can take once a month that prevent the HIV virus from replicating, and is like you don't have the disease anymore. Now there's still virus hidden places, so you still have to take the medicine. You can't stop the medicine. It doesn't cure you, but with either once a day or even now once a month treatment, you can keep the HIV totally at bay. The other one is like hepatitis C. We tried all kinds of diddly stuff for hepatitis C for 20 years. That worked a little bit, very expensive, really problematic. And now, over the last 5 years, we've come up with these antiviral drugs that stop this virus from replicating. And with hepatitis C, they're good enough that it actually cures you of hepatitis C in 12 weeks. So people have lived with years of hepatitis C and all the dangers from that. You start on the drug and they get better. So with COVID, the only one we have like that is one called remdesivir, which was a drug that was originally developed to treat Ebola. Didn't work very well. Then they brought it back to treat this. It works a little bit. That's called remdesivir. It works a little bit. But the research into the other ones has been shoddy. One guy working at night in his lab. We do not have the really strong approach to find out and that works. Now, I heard that there's a new one today called molnupiravir, trying to make these harder and harder to say, that does seem to be really quite effective. It can be taken orally, and it would be like Tamiflu for COVID. So you got the disease, take this medicine, you're very unlikely to get really sick, and that would be great. But we've done nothing on that, as best I can tell. And so the work on antiviral treatments is really going to be the key, because these variants are not likely to gain resistance to the antivirals. And so if it changes the surface of the protein on this, the antiviral drugs don't really work on the surface protein. So if the surface protein changes a lot, it's not going to change the inner workings. It's really the antivirals that work on the inner workings. So this would be another thing that I would put a lot of time and effort into. I mean, there are a lot of great antiviral drug researchers out there, and yet, as best I can tell, they've not been brought to the fore on what's going on. what's the third thing I do? I'd focus on these variants. It cannot take us a month to get the results back. We have to be able to get the results back within just a few days, and we have to recognize that these variants could scrap everything. Imagine if the P1 variant is circulating in Douglas County. We wouldn't know. We don't have any results back from February. So it could be widely spreading in Douglas County or Josephine County or anywhere else, and you wouldn't know about it for weeks later. And that would so change the way we would deal with this. So we truly have to focus on variants. The fourth thing I would do is I would really work on vaccine hesitancy. We are not going to get to enough people vaccinated until people who are hesitant about the vaccine get it. So right now, for example, in our nursing homes, about 50%, we think among our first respond or among our police forces, maybe 50%, maybe 50% of educators. We're never going to get to enough people immune to drive this disease down to a case a day if 50% of people say, I think I want to wait. So I think we really need to talk to people, find out why they're hesitant, and work through the issues about why they're hesitant, because getting the first 50% of the people vaccinated is going to be problematic. Getting that second 50% of the people vaccinated if they're hesitant is going to be almost impossible. So I would work on that. And the next one is we have to stay ready for the next pandemic. This is not the last pandemic. There could be another coronavirus out there that's lurking. There could be a flu, an avian flu that would be out there, or there could be there could be a virus like Ebola. So Ebola is a very different kind of virus. It's a very simple virus. It's got just a tiny, tiny little bit of material in it, but it's incredibly deadly. Right now, it only spreads through close contact. So it's unlikely to cause much of an issue because it doesn't spread by airborne. It doesn't have a lot of asymptomatic transmission. But you could imagine if this Ebola would change a little bit so that it could be respiratory, that this Ebola would change a little bit, that you had asymptomatic people, that could really change the game, right? So right now when you get Ebola, you get really, really sick. You're not going anywhere. You're going to lay in your bed and either live or die. So it's not like you're going out to a party and then the next day you figure you're sick. But imagine if there was now pre-symptomatic transmission. Imagine now if you could fly to the U.S. and be totally asymptomatic when you left Africa, and then when you come to the U.S. have infected a lot of people before you know you're sick. That could really spread. So we are going to have another pandemic. I absolutely promise you we're going to have another pandemic. I don't know what it's going to be or when it's going to be, but I promise you we're going to have another pandemic, either influenza, another COVID, variant of COVID, Ebola, or something else we don't even know about. So I saw an estimate the other day of hundreds of thousands of viruses that are circulating in animals around the world. And these animals and these viruses that circulate in animals typically cause anywhere from mild to severe disease in these other mammals, but don't spread to humans. But as human and animals get more close together, there's a big worry. So there's a big worry, for example, with bats. Bats are little rodents, but they've got a really weird immune system. Most mice and rats live kind of where they were born. They spread a little bit. They may live in little groups, but they don't live in enormous groups, and they don't spread very far. And so most mice don't spread a lot of disease, except for outdoor mice, like white-footed mice that spread Lyme disease. But for the most part, there's not a lot of spread among mice because they don't go that far, and they don't get together in these huge groups. Unlike bats, which go a long way, obviously, they're flying all around, and they roost together in caves typically with millions of others. And so if they had a normal immune system, bats would be wiped out frequently. Instead, what bats have is what's called a tolerant immune system. So their body does not make a big reaction to any virus, and so they tend to carry viruses. And so bats, for example, are the main carrier of rabies in Oregon because they get infected with rabies and they still fly around, infect other bats with rabies, and then come into your house and can infect you. And so we worry about bats. Well, if bats stayed in their area and we stayed in our area, that would be fine. But there are places where caving going in caves is a big deal. Well, if you go in the caves, there are bats in there, they're peeing and pooping on you, and you can go ahead and get this disease. So as we spread into areas where we do things like that, we can do it. Wet markets where we're selling animals could certainly do it. And as much as we think of wet markets mostly being in Asia, there's spread of other exotic animals in the US that could easily spread the disease. So we think this disease came in these things called pangolins, which are these spiny anteater kind of things. And if they're cute in pictures, I guess they're not that cute in real life. But if they were as cute in real life as, say, hedgehogs, or if they were cute in real life as, say, some of the birds, they could easily spread to places in the US. So we have to have better surveillance on these emerging things. And there are people around the world who are collecting bat poop all the time and sampling this stuff to see what's out there so that we can have an idea of what's coming rather than having it hit us once the disease is widespread in humans. The second thing we need to do about better preparedness is we have to have stuff ready. I mean, most hospitals during this time are in a just-in-time situation. So the surgical equipment that they're going to use on you next Thursday arrives on Monday, and then they use it on Thursday, and then the stuff they use for the next week arrives the next week. So it's like your kitchen having really no food in the refrigerator, and you're going to go to the store every day to get what you need. And that works out okay, except if something happens, everybody runs to the store at the same time and wants what you want to eat, or the store closes. So hospitals that did not have huge supplies, what they found was when there was this interruption in supply, because much of the supply comes from China, and China was using much of the PPE, they were drastically short on PPE. We as a country need to prepare. Every hospital and healthcare facility needs to have a 30-day supply of stuff on hand. The state needs to have another 30 days, and the feds need to have another 30 days. So we need to be ready for a 90-day supply disruption. Now there's a lot of cost on that in the beginning, right? So in the beginning, there's a lot of cost to build up that supply. But once you build it up, you're still using the same amount you're using before. And what you could do is you could work through these supplies so that if this happened again, it's like, oh my God, where are we going to get masks? You know, this idea that people were reusing surgical masks and reusing N95 masks is just heartbreaking. I mean, it's not like these things were very expensive before. It turned out we spent a tremendous amount of money because when these did become short, the prices on these were jacked up 10 or 100 times. And so N95 masks, I actually have a box that I look back on the invoice. It was 10 cents a mask for a standard that they're now well over $1 a piece now. So had we had enough stored before, we would do this. And again, this can't be just one hospital saying, hey, this would be a great idea, or one state that's saying this is a great idea. We as a nation need to do this. We need to have a 30-day supply at the federal level, a 30-day supply at the state level, and a 30-day supply at the local level. In addition, we need to be sure that we have enough local producers. Because although we say, oh, this is a worldwide market, it's a worldwide market until it's not. So it's a worldwide market until China has an outbreak and they decide not to export, or China has an outbreak and they can't produce. You can't, when it's something so important as medical gear like this, you do have to have providers in the US. And so before 2000, almost all of the PPE in the US was made in the US, and there was a little bit made in other countries. Now, almost all of it is made overseas and then shipped to us on a just-in-time basis. And while some of that's good, healthcare can't be just a just-in-time thing. I mean, if I don't get my Cheerios on time, or if the shirt I order on Amazon doesn't get here, it's not the end of the world. But if the people taking care of you in the hospital don't have N95 masks and whatever, that's crazy. The other part of preparedness is that systems have to be ready for a surge. So we were caught totally flat-footed with this. Now, I think in Douglas County we were better than most, but most places were caught totally flat-footed when this came, and their ability to surge up rapidly and get the people and whatever you need just wasn't there. So they put me in charge. I'd say, look, by the end of this pandemic, we're going to have 30, 30, and 30 for supplies. by the end of this pandemic, we are going to have a surge plan so that when something like this happens, we can deal with it. So we had computer systems that didn't work. We had hiring systems that were antiquated. We had research protocols that were made for normal times, but not adopted to the surge time. So put me in charge. What would I do? Better research on promising hunches. That a year into this, we don't know what works and doesn't is just totally embarrassing. Second is work on those antiviral treatments. Antiviral treatments are really a good way out, and yet we spend almost no time or effort on those. The third is we've got to focus on the variants, because the variants could totally derail this train, and unless you know what's ahead of you, we will get derailed. The fourth is that you really have to work on vaccine hesitancy, because I don't think we're going to get through this unless we get enough people vaccinated. And then the fifth is we have to stay ready for the next pandemic by having supplies, by really having a true plan, not just something written in a loose leaf book that nobody looks at, about what you would do if you had this big thing. So if you put me in charge. Okay, the last question we have here, and we'll be done then, is you've talked a lot in the past about what works and doesn't work. Could you put this together in a coherent strategy about what works to prevent COVID, what works for early treatment, what works for later treatment, and then all of these, what works and what doesn't? So I'll put this together. So we'll start with prevention. So what do we know works for prevention of COVID? Well, we clearly know that vaccine works. So we're very clear that the Moderna vaccine, that the COVID vaccine, that the Moderna vaccine, the Pfizer vaccine, and the J&J vaccine work. And we know they work because they had large, controlled, double-blind studies that showed that almost all of the disease in these groups were in the placebo group and not in the vaccinated group. And so we know that these vaccines are anywhere from 70 to 95% effective in preventing disease, and even better at preventing severe disease. So I think we know vaccines work. What about locally? Do we know that vaccines work? Well, I will tell you, if 28 of 29 were the people who were unvaccinated and 1 of 29 were the people who were vaccinated, it really does suggest that that data is correct. So I think that's the best hope. What other kind of things for prevention? Well, interestingly, a number of different studies have shown that eyeglasses seem to decrease your rate of transmission. So early on, there was a hunch in China that it's kind of interesting that a lot of people in China wear glasses, but almost nobody who wears glasses was in the ICU, and they've done it. And so glasses do seem to give some protection. The idea being that the little spritz of spray that people have can get in your eyes and maybe cause disease. The other one is vitamin D. A number of studies suggesting that people with low levels of vitamin D are much more likely to get sick or die from COVID than people with high levels of vitamin D. Still a little unclear if it's the vitamin D or vitamin D is a marker for something else, because again, outdoor marathon runners have high levels of vitamin D and have lower rates of COVID, but it may not be because of the vitamin D, it may be because they're outdoor marathon runners. So we don't know, but there's no sense that taking good dose of vitamin D, 1,000 or 2,000 units a day, is in any way harmful, and it might be helpful. So would you get a vaccine? Yes. Would you wear glasses? I do. And if you're not, you may pick out a pair of good-looking glasses to wear when you're around people, because that could give you an extra level of protection. And some people just think that glasses look great. And maybe take vitamin D. Yeah, I take vitamin D, so sometimes, I'm not very good at it, but you might do vitamin D. And then the public health measures, I think the data is increasingly clear that masks, social distancing, staying home when you're sick, all of those things we've told you about for the last year all work. So if you want to prevent it, what you should do, get a vaccine, think about wearing glasses, think about taking vitamin D, and do the masks and social distancing. What kind of things don't work? No good studies that other vitamins make a difference. So vitamin C or zinc works in prevention. There's no good data that ivermectin works as prevention. But vaccine, maybe glasses, maybe vitamin D, definitely masks and social distancing. Okay, so now you got it. Now you got it. What should you do for early treatment? Well, we've talked a little bit before about fluvoxamine, which is also called Luvox. Again, a study of that where they took people who were newly diagnosed, they gave them a bag, half of it had Luvox, half of it had a placebo. They followed them a few weeks later, and the people who got the Luvox were much less likely to get sick, much less likely to get hospitalized than people who didn't, so maybe Luvox. There's that antiviral that we just talked about before called molnupiravir. That could work to decrease that. That would be like Tamiflu that you would take for the flu, or Zovirax that you might take for shingles. That's an antiviral drug that might work. There's remdesivir, which is this drug that was developed to treat Ebola. It didn't work very well and works a little bit in COVID. It doesn't seem to change mortality very much, but it may decrease your time in the ICU, which would be a good thing. It may decrease your viral load, which is a good thing, but it's certainly not a home run. Monoclonal antibodies and the polyclonal antibodies, those do seem, again, new data suggesting that if early on you get one of these treatments, they're IV treatments, hard to get, complicated, but they do seem to work by decreasing hospitalization and decreasing death. So those would be great. We still have a crazy system in this country for delivering that. Again, these drugs would be absolutely ideal for nursing homes because the drug has to be given right after diagnosis. The drug has to be given intravenously. And so, I mean, obviously in nursing homes, people find out about disease very early because they're doing a lot of testing and they're already in nursing care. So getting an IV would be there, and they're very high risk. You know, for a 40-year-old who's got the disease, it's not exactly clear that the risk is high enough to support this. So monoclonal and polyclonal antibodies in the right settings. And then we have other ones, hydroxychloroquine. Hydroxychloroquine has been widely studied both in treatment after you get it, as prophylaxis once you've been exposed, and there are other people who take hydroxychloroquine on a regular basis for rheumatic disease. In none of those ways does hydroxychloroquine seem to work. So either taking it long-term for arthritis, if it really works, you should say that, well, geez, all those people with arthritis who are taking hydroxychloroquine, none of them seem to get COVID. It's not the case. They seem to get COVID at exactly the rate you'd expect. What about if you then got exposed taking a higher dose of hydroxychloroquine? Again, didn't seem to work. Or what about now when you get sick and get hospitalized treated with hydroxychloroquine? Again, didn't really seem to work. What about ivermectin? Well, ivermectin is an antiparasitic drug. And this is a hard one because there are some studies that make it look great. There are some studies that make it look terrible. And all of them have these funny endpoints. So again, when you look at a study, you'd love to have the endpoint be something that's really important, like did I die or not? That's really important. Did I have to get hospitalized or not? That's really important. Well, my viral load is on the 7th day. Not really that important to me. Now, if I survived more, if I was less likely to be in the hospital, and my viral load was lower, that would be great. But in terms of preventing death and hospitalizations, the data is kind of squishy. But again, I don't know whether it works or not, but this is why we've been talking about this for a whole year now. There's been 100 million cases since then. We certainly could have great data as to whether this works or not. So again, if you put me in charge, this is one of the ththings that I would do, is to do a good study, and in 2 weeks you could tell whether ivermectin worked or not. I would think right now, not very useful. Again, you want to look at important endpoints, death, hospitalizations. The other one's not so important. So I know people are sick of my baseball stories, but it's like, hey, we didn't leave many runners on base. Now, in general, not leaving a lot of runners on base is a good thing, but really important is, did you win the game? You could say, we had fewer bases on balls than the other team. That's an important thing. You don't want to throw a lot of walks. But on the other hand, not nearly as important as did you win the game. And so, again, on ivermectin, there's a lot of these studies that show you didn't leave many runners on base or you had no errors, but there's very few that says you won the game, which is that it prevented death. They've tried vitamin C and zinc for people who are sick. Doesn't seem to make a difference. And then convalescent plasma, which had a lot of hype early on. So convalescent plasma is the plasma you get from people who've had the disease. And it's been really disappointing. And it's been just miserably disappointing that when you give this to other people, they don't seem to get better. And why should that be? Well, it's probably because you don't have a lot of virus in the blood. may not have any actually, but you don't have very much virus in the blood. So the way convalescent plasma would have to work then is it would have to get to your lungs, get out into the lungs, and then work. And it may just be that with convalescent plasma, you're not getting enough antibodies to make it work. So again, with convalescent plasma, it's going to be one person's blood, 1/8 of the antibodies currently circulating. May not be a high enough dose. So convalescent plasma has really not worked very well. Okay, so let's say, so prevention, vaccine, mass social distancing, maybe glasses, maybe vitamin D. For early treatment, the polyclonal, monoclonal and polyclonal antibodies, maybe remdesivir, maybe Luvox, and then a little less likely ivermectin, hydroxychloroquine, vitamin C, zinc, and convalescent plasma. So let's say you're bad now, you're in the hospital, what works? Well, one of the things that clearly seems to work is prone positioning, which is so weird because as a pediatrician, we've known about prone positioning for years. So you have these babies who are just struggling to breathe on their back, and you turn them over on their bellies and let them prop themselves up like this, and they can breathe a lot better. And so, believe it or not, they tried this on adults who had COVID, and they seem to do well. And so prone positioning, putting people on their bellies, seems to work better than that. Why that works, there's some theoretical reasons, but nobody really knows. Early intubation probably does not help. So with many other lung diseases, if somebody starts to go downhill, you intubate them early, let the lungs rest, and they get better. With COVID, that does not seem to work, so early intubation is off. Oxygen clearly seems to work. There's one way to do it with this helmet thing. They put this helmet on you and blow oxygen at high levels and high pressures. Doesn't seem to work any better than just regular oxygen. Decadron, which is a steroid, really does seem to work. It decreases death rate, decreases time in the ICU. Decadron clearly works for people who are later and hospitalized. And then anticoagulants. So there's weird coagulation stuff that's happening with this disease. Clots. So you may have heard about people who get into kidney failure, usually because they have clots in their kidneys, or people who lose limbs because they have clots to their legs or arms. So it's really a cruel disease in that way. We see people with strokes because they have clots in the brain. So anticoagulants do seem to help with people who are in the later stages of treatment. So prone positioning, yes. Oxygen, yes. Decadron, yes. Anticoagulants, yes. Early intubation, no. Helmet, probably not. So this is what we got. So prevention, early treatment, and later treatment. How well does this work? Well, this has worked great. I mean, in the early days, this disease had a reproductive number of about 4. With masked social distancing in the beginning of vaccine, we've been able to drive it down to 1. So that shows that it works. On the early treatment, hospitalization rates for the disease have plummeted. So that it used to be that a high number of people were hospitalized. That number of people who are hospitalized, the percentage of the cases is way down. And then later treatment, overall, these are hospitalized patients. The risk of dying in the hospital started about 25% and is now down to 3 to 10%, depending upon which hospital you're at. So all of these really work. This is another reason not to say, oh, just let it blow through the community, because many of these things have come up in the last year. And if you just let this blow through the community, say in 2020, then you would not have had the benefit to reap the benefit of these learnings in 2021. And the hope is that as this disease gets less and less, that one of these treatments is going to be so good that even if there is some disease now in the community, you can say, oh, that's fine, let's try this molnupiravir. It works great, give it to them, and then this becomes important and a bother, but not nearly the worldwide pandemic it was before. The last question we'd have is, the last question we have here is about the Astrozonica vaccine and its use in Europe and its use in the US. So the Astrozonica vaccine, developed by University of Oxford and the AstraZeneca drug company, has been the problem child of all the vaccines. So the other vaccines had pretty clear trials, no big safety signals, and they've been there. The AstraZeneca vaccine has all kinds of troubles with its trials. Funny recruitment things, funny compliance with the schedule, they had a medication error, they had some early safety signals that were not well handled, and now they have this safety signal of coagulopathy associated with this. I think what it shows is that it may happen. It's really rare, 1 in a million, but when it does happen, it can be serious. I think those things put together are going to make people a little leery of this vaccine. And so they're going to go for vaccine approval, we understand, either in April or May, and we'll see what happens in April or May. But it'll be interesting to see if this comes through. So I think the U.S. did a good job by putting its eggs in several baskets, in the Moderna basket, in the Pfizer basket, in the J&J basket, and then the Novavax basket, which is another vaccine, because with that we'll have plenty of vaccine to get as many people who want vaccine vaccinated by this summer, and we may or may not wind up using the Astrozonica vaccine. Now, in an area where the disease is just rampant, I think you could take a 1 in a million risk from the vaccine if your risk of dying is 1 in 100. So I still think the AstraZeneca vaccine has a place. All right, well, that was it for questions from Facebook. Questions at DouglasPublicHealthNetwork.org. We'll do this again as our typical live session next Tuesday. But again, a couple of things we're asking people to do is still be careful about travel, still be careful about unmasked situations. Please, please, please get your vaccine. And first and foremost, be safe and be kind. Again, Dr. Bob Dannenhoffer, the Public Health Officer, Douglas County. Thanks.